Hello, everyone. We have a very, very important talk today on the hypersensitivity reactions and safety issues of the COVID-19 vaccines by Professor Mariana Castells, who is the director of the Dry Hypersensitivity Center at the Brigham Women and Children and a professor of medicine at the Harvard Medical School. Professor Castells is a world-renowned expert in the field of drug allergy. We are in the midst of a global pandemic, the COVID-19, and finally we have vaccines here that will help us to overcome this pandemic. However, we have certain challenges, and those challenges lie in the safety and the hypersensitivity reactions that patients may develop as a result of being vaccinated. How do we prevent that? How are we better prepared for it? What are the factors we should consider? And what are the guidelines we should create? And what is the guidance that we should give to our membership and to our member countries? This is what will be covered by her talk, which is based on her publication in the New England Journal of Medicine. So, Professor Mariana Castells, we welcome you to start your talk.
Thank you very much for inviting me, Dr. Prawankar and Dr. Thong. I am delighted to be here today to talk about safety for mRNA vaccinations. And in this work that was published by Dr. Elizabeth Phillips, my colleague in Vanderbilt University, and myself, we described the potential reactions and the reactions that could occur with this unprecedented vaccine that is made of messenger RNA. As we all know, this is a vaccination form that has not been utilized in the past, and this is the first time that we have been able, through unprecedented breakthrough in technology, be able to encapsulate messenger RNA that contain the spike protein that is released, that is encoded inside nanoparticles, and that is released in the human body and is able to be encoding and create the protein that is now seen by the immune system and create antibodies against this. And the efficiency, effectiveness, and protection that this has provided has been also unprecedented with 95% protection. The potential reactions that occur with vaccines are 1 in a million. And since the beginning of the vaccination with messenger RNA vaccines, we have seen that the frequency of the reactions have actually increased to about 1 in 100,000. The reactions that I will describe to you have being immediate reactions, and we are in this time investigating whether it's IG or non-IG reactions. There are some also acute vasovagal reactions that could account for syncope, and then there are delayed reactions, site reactions, urticaria, potentially serum sickness, which we have not described yet or seen yet, fevers and delayed rashes. And again, the important thing about those reactions is the recognition, recognizing the phenotype of the reaction based on the symptoms, and then trying to further understand by a detailed history the potential cause of that, doing a thorough physical examination, documenting what has happened and when, and then having a serum tryptase drawn and storing some sample of the blood to be able to eventually do specific IgEs and or complement activation and other tests, and do a mechanistic assessment of whether the patient can actually be received due to the severity of the reaction, the second vaccine, and then make the vaccine safer for the population. We have now here that those are the vaccines that are available, messenger RNA vaccines based on BioNTech, Pfizer, and Moderna. Those vaccines need 2 doses and actually contain polyethylene glycol 2000, which is the base of the nanoparticles. There are rare patients in the general population who are sensitized to polyethylene glycol, and it is possible that those patients could be at risk for those vaccination. Again, rare patients. Then there would be adenoviruses, which will require just one dose, and those contain polysorbate 80, and polysorbate 80 is related to polyethylene glycol, but again, rare patients in the general population have presented sensitization to those compounds and could be at risk for those vaccines. And then protein vaccines, which again require 2 doses from other companies, do contain also polysorbate either 80 or 20, indicating that patients could also be potentially at risk. And we have actually seen through work from my colleagues that patients sensitized to polyethylene glycols and polysorbates do present, as you can see here, positive skin testing, and we also have been able to identify specific IgGs in the blood for those patients. So those tests could be available to them. And you have here that this is the patient 1 and the patient 2 sensitized to polyethylene glycol through positive skin testing here, and sensitized to polysorbate 80 sensitized here. So again, in one patient, we can have potentially 2 sensitizations, and patients can be sensitized to just 1. We have now, and we share that with you and with the rest of the world, the potential recommended testing for polyethylene glycol and polysorbate, which is here and contains the evaluation of through Miralax and methylprenylsilone acetate, dipomedrol, for the polyethylene glycol 3350. Then we have also for polysorbate some eye drops that can be used, and we have also for polysorbate 20 other compounds such as hepatitis A vaccine or Twinrix that are also potentially used for the evaluation of those sensitivities. And again, those are the non-irritant concentrations and can be readily available. And we have actually used ourselves at the Brigham, at the Mass General Hospital, at the Partners Hospital in Boston, very useful to identify people who said have reacted in the past to potentially some medications that contain those, and identifying them as potential reactors to the vaccines. The vaccination reactions are listed here, and I will briefly review those reactions from Pfizer, BioNTech. Several of those reactions, the first 2 occurred in the UK, but there are others that have occurred in the United States. Essentially, the patients who have reacted are a majority of females, but again, due to the fact that healthcare workers are leaning towards a female predominance. This is the history of those patients, the past history, which contains some of them allergies to whether foods, bee stings, environmental allergens, or other medications, other drugs. And some patients did had previously anaphylaxis, but the majority didn't. And the reaction onset is quick and within 2 minutes, and the majority is within 13 minutes, although there was one delayed. And the symptoms are very consistent with a phenotype of a type 1 reaction, whether it's a diffuse erythematous rash, generalized urticaria, some wheezing, again, angioedema, swollen throat. So all those symptoms were actually treated with epinephrine, with a very few, I think 2 exceptions, and actually responded well. And all the patients were discharged home, and there was no prolonged hospitalization. They were treated in the emergency room. So again, the reactions that have occurred and have been consistent with those, mostly those hypersensitivity reactions, in addition to local reactions and delayed reactions to the vaccine. I have a summary here of what I was mentioning to you, which indicates that those reactions could be a quick 13 minutes as a median range, and then the symptoms are consistent with the type 1 reactions. And some of the patients, again, had documented allergies, the majority of them in this vaccine, and a few of them, 1/3 of them, had experienced anaphylaxis in the past or reactions to vaccine. And Other reactions that are consistent with hypersensitivity include 83 more cases that are not anaphylactic. Again, the non-allergic or non-anaphylactic reactions include scratchy sensation in the throat, mild respiratory symptoms of rash, either local or more generalized, and some pruritus. We have now that we have also been aware of the reactions that have occurred with Moderna vaccine because it was approved a couple of weeks later than the Pfizer vaccine for emergency use in the USA and around the world. And again, there's a collection of patients, around 10 patients, who have experienced those acute hypersensitivity reactions, including anaphylaxis, with a predominance of females. Again, with some of them having a background of allergy or hypersensitivity, and with some of them having had anaphylactic reactions to medications. And the onset, again, of the reactions have been extremely fast, from 1 minute to a few minutes, with only one delayed, as in the other vaccine. And the symptoms very much consistent with symptoms of hypersensitivity reactions and anaphylaxis, again with skin manifestations, angioedema, some hypertension, wheezing. All the patients receive epinephrine and all the patients were discharged home. So we have no deaths have been reported after those reactions. So I wanted to summarize that the reactions are also based on the Brighton definitions of anaphylaxis, with the level 1 being a certainty and level 2 or 3 being potential anaphylaxis. And the symptoms that occur, I have described to you, are mostly dermatological, cardiovascular, respiratory, gastrointestinal, and again, mast cell tryptase is the key of those evaluations, and obtaining some blood at the time of the reaction and doing later analysis is also a valid approach to those reactions to make them safer. So I would stop here and entertain any questions.
Thank you, Professor Mariana. That was an excellent talk and really on such an important aspect. And we have so many burning questions actually for you. So together with Professor Tong, Bernard Tong, our board of director and also web editor, we would like to ask you several questions, and we look forward to your valuable input that will really help our membership as the vaccine gets rolled out in this region, which is happening slowly, but in the next months. So, Professor Bernard, would you initiate the questions?
Yes, sure. Thank you very much, Professor Castells, for that very informative talk. So I think it's just good timing, because in Singapore we are, I think, one of the first few Asian countries to have started vaccination, mostly the healthcare workers first, and we're next moving on to the elderly population. And the vaccine that we're giving currently is Pfizer. So in my experience in the last 3 weeks since we started vaccinating the healthcare workers, I think some interesting patterns have evolved. So one of the problems we have here in Singapore is trying to risk stratify the patients who should not receive the vaccines. And looking at some of the data from the 2 MMWR papers, it does appear as if, in terms of risk factor stratification, the likelihood of patients having, say, allergic rhinitis, food allergies, drug allergies, and the likelihood of them getting anaphylaxis, there doesn't seem to be a very clear association, isn't it? How would you use the MMWR data to perhaps risk stratify patients who might react and who you would avoid vaccinating?
Yes, I agree with you that when we started vaccinating patients, there was a concern that potentially patients with severe asthma or patients with food allergies or patients with drug allergies would be at risk, and we have not seen that. So essentially, patients who have our risk stratification involves patients who have reacted to vaccines in the past and patients who have reacted to either polyethylene glycol or polysorbate, and those patients are stratified by skin testing. So in our hands, the only patients that we would not vaccinate at this moment with the available mRNA vaccines would be patients who have actually positive skin testing to any one of those components. But essentially anybody else is actually available to be vaccinated regardless of their allergy history. And as I mentioned before, although some patients have had food allergies and environmental allergies and drug allergies in the past, that has not been a pattern. So again, the frequency of those reactions have been extremely low. At this moment, it may be lower than 1 in 100,000. And again, a variety of those patients never had allergies.
Yeah. So one of the challenges we had in Singapore up to now is that we have vaccinated about 110,000 individuals, and just out of those 110,000 individuals alone, we've had 4 cases of adjudicated anaphylaxis. And that's following the Brighton classification criteria. So because of that, of course, there's a little bit of concern because our denominator is nowhere near the denominator in the US and UK. So that's why our regulatory agencies are probably a little bit cautious currently.
Well, I have to say, Professor Thong, that when the UK was starting vaccinating, they had 2 anaphylactic events after they vaccinated less than 1,000 patients. So again, there was like almost a sense of panic that the frequency of those vaccinations was going to be, either 1 in 100, 1 in 1,000, so extremely high. But as the numbers have expanded, then those numbers have remained very low, like I said, and the frequency has remained extremely consistent between the UK and the United States, about 1 in 100,000, no more than that.
Yeah. One of the challenges we face is trying to identify individuals who have been sensitized to PEG and polysorbate. Because in our taking of the drug history, for example, well, PEG and polysorbate is really present in not just parenteral medications, but lots of oral medications, eye drops, even topicals. How do you discern then the likelihood of exposure and the risk of sensitization versus clinical allergy in these individuals?
Right. That's a very interesting question. We don't have like a way except for a questionnaire. We have a questionnaire that we give to all the patients. Have you ever reacted to eye drops? Have you ever reacted to Miralax or to some other substances? And based on that, if the answer is no, the patient is actually deemed not at risk. And again, whether the exposure that's what we were saying, that the exposure to those substances, how much is sensitizing? It's a really good, question. We think that those substances are not very sensitizing because the majority of the population has been exposed to those substances without any anaphylactic reaction or HEP sensitivity reaction. Again, so the denominator is very high and the numerator is very low. So the frequency of sensitization is extremely low and has to be triggered by a questionnaire.
Yeah. What do you think is the mechanism for the delayed reactions? Some of the delayed reactions that we've been seeing are a little bit unusual. We get delayed urticaria and angioedema even up to 4 to 6 days after the vaccination with no other discernible cofactors. These are individuals who have had episodic urticaria but never any overt rhinitis, asthma, or even food allergy symptoms. And it seems to be rather sudden. I don't understand what the mechanism is actually.
Yeah, no, that's again a very important question we have not been able to answer. The NIH is very interested, and I'm part of an effort to try to understand the mechanisms of those reactions. And again, as I was mentioning, obtaining a tryptase is crucial because then we will be able to see if there was like mast cell activation, whether IgE or non-IgE. What I can tell you is the particles that are made, the nanoparticles, whether polyethylene glycol polysorbate, those particles are not deposed immediately. So it takes a little bit of a time for those and could potentially be activating some other non-IgE pathways. So we are very interested in complement activation, for example, looking at CH50, looking at C5a, C3a to see if those could potentially be the mechanisms of those reactions. In few cases, there might be potentially an IgE mediated reaction, but again, we do think that there is a component of non-IgE mediated reactions, and whether we have already seen patients in which tryptase has been elevated at the time of the reactions, we have some indication that the mechanism of those reactions is mediated through mast cells, whether, again, Ig or non-Ig.
Yeah. Do you think some of these reactions may be like the kind of infusion reactions you see with certain chemotherapy drugs and biologicals, perhaps a cytokine-mediated pathway as well?
We have not seen any of those phenotypes yet. As I was mentioning at the beginning, now that we have the vaccines, we also will have some monoclonals that are available, blocking monoclonals, and those do have a certain rate of infusion reactions. The infusion reactions are slightly different in terms of the presentation. They start with rigors, with chills, with fevers. There is some pain, either chest or back. They can be, and there is usually not associated with urticaria or angioedema or the typical signs, cutaneous signs. So again, there is a differentiation of symptoms, and none of those have been occurring with the vaccines. The no cytokine release phenotypes we have seen.
Right. So for your patients in the US who have a delayed reaction, but just mainly skin, say an exanthematous reaction or a fairly severe maculopapular eruption, do you give them the second dose?
We have been risk stratifying those patients if the reaction is very prolonged, requires steroids. So again, the stratification. If it's urticaria that lasted less than 24 hours, some of those patients will take an antihistamine before the second dose. But again, those delayed reactions are of concern for potential. We have not yet had any Stevens-Johnson or stress or any of those reactions, but they would be a concern if they are prolonged and do not respond quickly to an antihistamine and require some steroids.
Okay. Ruby, hand over to you.
Thank you very much, Mariana, for all these answering these questions. Just in connection with what Professor Tong already asked and what you beautifully answered, I just was wondering that one is, of course, I think it would be very nice if you could share with us the questionnaire that you use, because we are actually in a region where there is so much of disparity. You have countries like Singapore, where the system is so well established, Japan so well established, Korea so well established, Taiwan, yes, or Hong Kong. But then you have so many other countries where there is not an awareness of anaphylaxis, where EpiPen is not available, and those countries are like burdened with COVID. For example, India and Thailand, Philippines. Of course, awareness is more in Philippines and Thailand compared to India. So something like that questionnaire would be very helpful. And we want to be of service to our community. We're trying to provide as much guidance as we can for the government and for also the HCPs. So one is that. The other is, I'd like to know is like, what would be the very strict criteria where you would say, okay, we cannot give the second dose to this patient because of this particular reaction? Where is the cutoff? I mean, what's the real cutoff for that?
Right. Thank you, Professor Pawanka. The questionnaire is readily available, so I'm happy to share. There is, I think, almost a universal questionnaire that I will definitely share for, and it contains the questions: have you ever reacted to a vaccine? Have you ever reacted to an IV medication? Have you ever had anaphylaxis? And again, those are the three the most important questions, and then if yes to any one of them, then the patient is further evaluated by an allergist, and then we make the final decision about who would be the patient who cannot be vaccinated. So, for example, patients who have had severe reactions that to vaccines in the past, and those reactions may not even have been anaphylactic neurological reactions, Guillain-Barré or some other neurological reactions. Those are patients who may not actually be candidates for vaccination if they were prolonged hospitalization or permanent damage. Again, patients who have had anaphylaxis to some other medications may be screened by either skin testing or some other mean, and then decided on potential vaccination. So the word is that patients with allergies are actually very good candidates for those vaccines, and only patients who have had reactions to some of the components of the vaccine would be potentially the ones that would not be candidates. Having said that, once a patient reacts to the first dose of the vaccine, that is, different. So then it really needs a risk stratification. One of the patients who was presented with Moderna vaccine had a pretty severe anaphylactic reaction, all correctable with epinephrine. As I said, nobody has been hospitalized for those reactions. The patient was actually tested. We have the luxury of being able to test for antibodies to the vaccine, to some of those, and the patient has very high levels after one dose of the Moderna vaccine. And there has been, in the different, CDCs and FDAs now some thought about only giving one dose instead of two. This particular patient I'm talking to had very high levels of antibodies and is not going to have the second vaccination for the one that he received first. So again, there are no exclusion for vaccination that is written in stone, and this is very personalized medicine. And with the questionnaire, we have been, able to help, I would say, 99% of the people to get vaccinated.
Yeah, the other point that I really was very concerned about is in countries where the pandemic is, there's so many cases, new cases like in United States or UK, where people are already getting infected, and as compared to countries where there's low level of infection. So how would you place the benefit of vaccination in these two scenarios?
Again, in countries where at the beginning of the UK and in the United States, the rate of infections was low, and it started to increase exponentially over time, and we do have a lot of people who are carriers that are actually not symptomatic. So again, in countries where there is not a lot of infection at this moment, this might be a point in time. I'm not really sure about the spread of the infection, about potential asymptomatic carriers. So I do think that the vaccine is needed in every country. I'm not really sure that we can exclude anybody. Whether the vaccine is needed today or tomorrow, that's another question. In the United States, we need the vaccine today, and that's why we're vaccinating. And in Europe, the vaccine is needed today. But whether other countries will need it over time, that's something that will be evaluated at each place.
I mean, with so many different vaccines coming out right now, and these kind of reactions could occur with the newer vaccines. I mean, do you have any idea of what the one that's coming out from J&J, Novavax, and there are of course so many other vaccines like from China, the Sinovac and Sputnik, and so I mean, there's so many people from different countries actually getting it. So do you have some
Yeah, I have to say that, all the vaccines that are available have had shortened phase 3 clinical trials. The phase 3 normally includes several thousand, and at the most what we have seen with the first ones have been, 30 to 40,000 people, not 100,000. So again, those are shortened phase 3 clinical trials, and we haven't seen everything. But now we have several million people who have actually been vaccinated, and again, the side effects have been quite amenable to treatment. So we have not had neurological side effects that that have been seen. We have seen those hypersensitivity reactions that have been amenable to antihistamines and epinephrine. So again, we know a lot more about those vaccines, and again, those reactions are all amenable to treatment and are not, they might be life-threatening in very few cases. So again, we know a lot more. We will know a lot more in the next, few weeks, a few months about potential reactions. But so far, what we have seen is very encouraging because all the reactions have been treatable and all the patients have been able to receive their vaccination, even like I said, with many allergies.
With the percentage of the population getting infected naturally and with the vaccinations being rolled out in huge numbers, what percentage of the population do you think uh, is should be zero positive to have the herd immunity?
I think that, that was a good question, a few months ago. Right now, we have a more pressing question, which is, the mutant vaccination, the mutant virus. And we have some from the UK, some from Brazil, some from South Africa. We think maybe there were mutant viruses in the United States. So again, I think the important question is, are the vaccines that we have available, addressing those mutants? And I think that, there's a lot of studies ongoing. As every single day we are sent studies from people who have been infected with this vaccine, those viruses that are now mutated, and the response to the vaccine has been positive, although in some cases less, effective than it had been to the natural virus. So again, I think that now this is like a little bit of we have a marathon to run. Now we have a sprint to run. We have to be able to vaccinate as many people so that to avoid that the virus mutates. And I'm not really sure that we can know how many people, but a large amount of the population needs to be vaccinated to avoid that pressure, that selective pressure that the virus is having at this present time. And that selective pressure pushes through mutations. And so far, the mutations that we have been responsive to, in some way, to the vaccines. But whether this will continue like that, again, it depends only on the rate of vaccination and the speed of vaccination.
One of the things that both CDC or the UK government or EMA have actually said that the caution is mainly for those with drug allergies or prior history of allergies to vaccines. Food allergies are not really included as a contraindication or a risk factor. But there are cases of shellfish allergy patients actually having urticaria or anaphylactic reactions to the vaccine. So, is there something that you would like to highlight, or is it better that we advise these patients to pre-medicate themselves to avoid such a reaction?
I agree with you, Dr. Pawankar, that some of the patients that I presented from both vaccines had food allergies, shellfish allergy and fish allergy. And those patients were, and one of the patients actually has become my patient and had pretty severe food allergies in the past to shrimp, to lobster, to everything, and reacted. Again, because we don't understand yet the mechanism of those reactions and what is the component, the allergen of those vaccines. The things that we can actually suggest to our patients is that if we have patients who have anaphylaxis to food, they need to carry their EpiPens to the site, and potentially they can take an antihistamine before and potentially look at monitoring them a little bit longer. So instead of 15 minutes, 30 minutes, which is what we have been recommended. But again, whether this is like a signal, we need many more numbers of vaccinated people to understand if food allergies are a signal. And so far, we're just recommending that patients with very severe food allergies with anaphylaxis carry their EpiPens, are monitored for a little bit longer, and then potentially take their antihistamine. So we have told our allergic patients to continue to take their medications. So whatever they take on the day of the vaccination, they have to continue taking. And so that actually might be protecting those patients too.
Yeah, I mean that raises the same question that I raised before, because in our region there are many countries that don't have EpiPen, and I mean what we would suggest is like have a pre-filled syringe of adrenaline, so you can administer in case of emergency, like an emergency cart that when these patients are being vaccinated. And also the question rises that there are people who are not aware that they're allergic to certain drugs or certain or crustaceans, just because the awareness is so low. And the COVID actually affects everybody. I mean, it's literally class non-specific, geographical boundary non-specific, so gender non-specific. So how do we deal with these kind of situations? I mean, I guess the only way is to have an emergency cart with everything ready um, at the site of vaccination. And the question again occurs there is that if you're in a hospital background, on a clinic atmosphere, you can have that. Well, what happens if you're at an outside venue vaccinating a lot of people in an outside venue? What would we do?
So I think that those are very important questions. Every place where vaccination requires to have some epinephrine available, whether you know, the pre-filled syringes or the syringes loaded. We have, you know, here in the United States, CVS is a brand of pharmacy. We have a lot of people who are going to be vaccinated at CVS places. So in those, there would be people who have never had a reaction, people who have not had an anaphylactic event. So the proposition is that people who have to use an EpiPen in the past and who had a very severe, you know, allergic reaction, is people who we need to vaccinate in the hospital, you know, with a crash cart at the bedside, and making sure that even if they don't have an EpiPen available to them, there is epinephrine available. So I do agree that people with a history of anaphylaxis, with a history of a very severe allergy, needs to be vaccinated in a place where there would be epinephrine, because epinephrine has been shown to be the responsive to all those reactions. Nobody has actually failed to respond to that. And so epinephrine is the drug that needs to be available.
Would you also say that after administering epinephrine, they should also be given an antihistamine and a steroid, or would you avoid the steroid?
Yeah, the antihistamine is perfectly all right, whether antihistamine is available. The role of steroids is non-existent in anaphylaxis. You know, we don't have a role for steroids there, but again, some people have proposed a small amount of steroids to avoid delayed or protracted anaphylaxis. Again, we don't do that systematically in our centers. We use the epinephrine and then an antihistamine.
Oh, thank you very much. And my last question is from my side, if Professor Tong would ask some more, uh, he may do so. But my last question is, with this real inequality of the distribution of the vaccines, we're seeing that not all countries are getting it. It's not being rolled out equally. And there are some countries who probably don't even know when they're likely to get the vaccines. So uh, with the extent of which this pandemic is, it's going to take a long time before we can literally return to normal, because travel would be almost impossible if we have to have this disparity, that there are countries where you have vaccinated people, but there are other countries where people are not yet vaccinated, or there are groups of people that are not vaccinated within a country. And of course, that's the task that WHO and has to take care of. But I mean, is there something that you would like to comment on that?
I think that this is a real world concern, and pharmaceutical companies are well aware of this. And I believe there are some collaborations that have been generated at this moment between pharmaceutical companies with capacity to produce, as many vaccinations as possible. Like if we think about the flu vaccine, there are several companies, and I will not mention, that have capacity for worldwide distribution. So again, at this moment, I do think there is is a concerted effort to be able to produce this vaccine in the highest amount. And again, with 17 or more vaccines that are very close to, completed phase 2, phase 3, I do believe that there is like a world effort to produce mass production of one vaccine over another. And the thing about it is, the more we vaccinate people, the more we know about the potential side effects also. So I think that if we learn about side effects in the United States or Europe, that would actually be applicable to all the Asian countries, African countries, or the rest of the world. So as we learn, we share knowledge, and I think that is extremely important, that as we understand further what's happening. And I agree with you that there is not a clear vision of when the rest of the world and the world itself will be vaccinated. And as I mentioned, we have very pressing needs at this moment to understand how the virus is mutating, because I don't think that this is a trivial question. Under pressure, the virus could become very resistant and use the spike protein, which is like what is targeting by many of the vaccines, to change the structure, to add some glycosylation, and then to be very difficult to address with the current vaccine designs that we have. So again, the time is short. We do need to act quickly, and every effort that we have, the reason I'm talking to you today is because I do see this effort. I have given over the weekend a talk in Europe and a talk in Peru, and I actually have emphasized the need to push upon our institutions and governments for fast vaccination as much as possible.
Thank you very much. That's been very, very helpful. And Professor Tong, would you like to ask any more questions?
No, I think we're good for today. That was an extremely enlightening sharing, and I think we learned a lot from the experience there. So time for us to start in Asia.
Yes, thank you very, very much. Actually,
Thank you both.
The learnings that we have from your talk and the discussion is really, really going to be very important for us. We've just come up with recommendations, a task force recommendations for the severe adverse reactions to COVID-19 vaccines, and it's on our website. I'll share with you the link. Bernard has led this. I've worked with him for it, and we're chairing that committee, and we'd love you to be our advisor for that.
Well, thank you very much. As much as my knowledge, is available, I'll be happy to share, definitely.
And we're also coming up with an online module that can be shared with the HCPs so that they understand because I've received these kind of questions even coming from Philippines, for example. They don't have EpiPens. So do we need to fill insulin syringe? How do we manage that? And, little things like that. So we want to give the maximum amount of guidance to our membership in our region. So
thank you so much.
A tough task.
Thank you so much for inviting me, and I hope the knowledge serves, across the world. Thank you. And thank you for sharing, for doing what you do. Actually, it's so important.
Thank you very much. Thank you.
Okay, thank you. Bye.
Bye.
Thank you. Bye.